Hello, everyone. My name is Zaccaria Ricci, and I work in Florence, Italy. My topic is pediatric acute kidney injury and sepsis. This is the outline of my speech. I will talk about the incidence, the pathophysiology, some risk factors, outcomes, and whatever available today for therapeutic management of this difficult disease. What we currently know about acute kidney injury epidemiology in general comes from these two important studies, the AWARE and the AWAKEN study, published some years ago, but currently pivotal as far as our knowledge of pediatric acute kidney injury is concerned. We currently know that in pediatric ICUs, AKI incidence is about one child over 4 that are admitted in the ICU, but severe AKI is 1 on 10 patients. About 1.5% of these patients in this study, I have to remember that cardiac surgery children were properly excluded by the study. However, RRT is due in 1.5% of patients. Similar things have been shown in neonates, and about the same numbers were found by the authors. And again, the CRT in these patients is quite rare. Something different occurs when we are specifically dealing about septic AKI, because we currently know that it represents about 1/2 of all AKI cases. However, regardless which classification is used, I would like to remember that currently it is recommended to use the KDIGO classification to classify AKI even in children. Half of this 50% of AKI cases had a severe stage of AKI. Again, very important, the awareness currently that only severe stages are those who have a significant impact on patients' clinical course and outcome. Again, septic AKI patients, with respect of the overall cohort of AKI patients, are almost doubled. If we go and see the total group of the septic patients, again, AKI has an incidence of more than half of all patients. So every time we are dealing with sepsis in children, we have to take into consideration the possibility of an AKI episode. This is a wonderful review in general about AKI published a couple of years ago on Lancet by the triad of the most influential authors of the field. And you can see easily how sepsis has an important role in the overall world of AKI, and that it correlates strictly with the hemodynamics and drugs, as we will see in a moment. The current view of septic pathophysiology, both in children and adults, is that there is a dysregulation of the normal reaction to pathogen that in normal clinical course leads to healing of patients. And this reaction to the pathogen implies both inflammatory and immunoreactive agents and immunosuppressive reactions. When one of these two pathways is indeed dysregulated by the immunophenotype of the patients or by the particular interaction in that clinical case of DAMPs, the damage-associated molecular patterns of the PAMPs, the pathogen-associated molecular patterns that are the triggers of this response. Every time there is a dysregulated pathway, distal organs are also involved. And clearly, the kidneys are one of the most affected organs, and generally one of the first in the time course of the disease. And you can see in this picture that the DAMPs and PAMPs can be filtered into the tubular lumen and directly cause a damage into the cells and into the lumen, with the final release of chloride that is well known to act as a negative agent against the glomerular filtration rate. Also, other authors have underlined the pathophysiology of septic AKI in hemodynamic terms. It is currently not clear if the renal blood flow is indeed decreased or preserved during septic AKI. It is possible that the macro circulation of kidneys is preserved, especially when an aggressive treatment is performed, and when the minimal pressure of these pressure is conserved, is preserved by vasoactive agents. But probably there is an issue at the microcirculatory level with a possibility of opening of intraglomerular, intratubular shunts, with the ultimate hypoxia of the tubules that might be in action as a damage pattern in this condition. Finally, we have to remember the detrimental action of the fluid overload. This is particularly important in children. We well know that fluid overload has been studied in many settings of the pediatric critical care, and for sure also at the septic setting it has a role because as you can see in this other slide, it can cause problems at the microvascular level with a direct spillover of fluid through the endothelium, causing edema at the tubular level, edema in the whole organ, causing a sort of increased pressure in a encapsulated organ like is the kidney, causing a sort of congestion of the kidney, and direct damage of some agents. For example, the synthetic colloids can have been identified as causes of direct damage at the renal site. So when we go and take a look at the studies that explored in children the risk factors for AKI during sepsis, we can find that for sure hematologic and immunologic comorbidities, implying the possibility that these patients undergo a dysregulation of their immunologic reactions. Malignancies, again, chronic kidney disease, well known to cause a disruption of immunoregulation in children, abdominal infection, the severity of the admission disease for sure, but also the minimum systolic pressure below the 5th percentile for age. And this is particularly interesting to me because when we go and take a look what the Surviving Sepsis campaign for septic shock in children say, they clearly remark that we have a lot of doubts what is the minimal arterial pressure that should be aimed in these patients, and that we are uncertain what are the lower blood pressure that are acceptable in children. And so it is very difficult to currently know how aggressively and with which target which should resuscitate and increase the pressure of our children during a septic episode in order to protect the kidneys. Obviously, another important factor should be taken into consideration, that is the maximum vasoactive inotropic score, and for sure we have to preserve the mean arterial pressure in these patients, but probably we have also to consider the possibility that our vasoactives can induce a damage to our kidneys or be associated with probably in patients with the most severe hemodynamic derangements. Also, as clearly identified by this study, as I was implying earlier, fluid overload in this case is above 15% after 48 hours from sepsis recognition is an independent factor associated with acute kidney injury during sepsis in children. What is concerned about the outcomes of these patients, we know that more than 50% had a severe AKI, and as I was saying earlier, this study confirms the high rate of patients who require CKRT during a septic episode. Then twice as many patients as compared with the overall AKI, with the overall septic population had the risk of dying. So twice patients with AKI with respect to septic children without AKI had the risk of dying. So AKI is indeed associated with death in these patients. And this is an independent factor associated with death. Obviously, they had longer mechanical ventilation. These are all commonly identified hard outcomes in this patient. But what is interesting in this study is that also medium and long-term outcomes are impacted by an AKI episode in septic children. And in particular, in this study, the authors identified a poor functional status score in septic AKI children. And in an editorial that I wrote with my friend Rajit Basu, we remarked that this study clearly demonstrated that the scar that AKI in septic children is caused by sepsis is able to impact also into children's physical, mental, and emotional status. So this has to be taken into consideration on how important it is to identify AKI as a prognostic factor and probably identify AKI in order to treat it as much as possible and as much as aggressively possible. So dealing with prevention, I think that the most important factor that we have to deal with are drugs. Certainly these children receive a lot of antibiotics that are the mainstay of the therapy of sepsis, but antibiotics are one of the most important nephrotoxins that children receive. And the Ninja is presented during this meeting very smartly by his main author, that is Professor Goldstein. But it is important here to remark that the brilliant things that they were able to show, in particular, that a lot of children receive nephrotoxic drugs, and once you are able to identify them, as they did with an electronic alert and a direct human action into the service that is prescribing these drugs, they were able to show how the Ninja, this is the name, the cool name of this project, was able to significantly decrease the rate of the nephrotoxic medication. What is the possibility to apply this in septic children? This is currently not known, but I'm sure that in the Ninja speech, Dr. Golsing was able to show all the details of this approach and all the promises of this important aspect that is essentially nephrotoxic drug stewardship and AKI prevention. What we currently know, and this has been repeated in many studies, is that the combination of vancomycin and beta-lactam antibiotic is one of the most important and impactful nephrotoxins in our children. And this combo has to be clearly very carefully prescribed, and whenever possible it should be switched, especially when we see that initial AKI episode is being caused. It should be switched to another combination of drugs. And in this case, they clearly showed how different is the clinical course of patients receiving piptazo and vancomycin with respect to those receiving vancomycin with another drug, another antibiotic. And again, this was independently associated with an antibiotic associated AKI in this study and many other studies that have been published in the last 5 years. Do we have any possibility of treating an AKI episode? So we generally tend to talk about the prevention methods in these children, but we do not know, and we do not have any agent currently known about what to do when AKI is already there. There is some interesting promise about alkaline phosphatase. We probably know that ALP functions by an action of dephosphorylation in humans, and this dephosphorylation might be effective in inactivation of LPS. That is one of the main triggers of the toll receptor, toll-like receptor that cause renal and systemic inflammation, and also dephosphorylating ATP in the damaged, inflamed tissue in order to blunt in some way the cytokine production and the tissue damage. Recently, a preliminary study has been conducted in adults, and this is very important because this was following other preliminary studies that were somehow showing the effectiveness of alkaline phosphatase in septic AKI. And this was a sort of preliminary randomized multicentric studies, very complex because these authors had to also to identify the exact dose that had to be administered to patient of alkaline phosphatase. They randomized 290 patients from 53 centers. They identified the ideal dose that was 1.6 milligram per kilogram, and the drug was administered after septic AKI was diagnosed. This is the first approach to treat AKI after its identification and not as a measure of prevention, like all the other drugs that, by the way, have failed, have been attempted. This study showed essentially that the ALP was safe. The primary efficacy endpoint did not show a significant improvement in glomerular filtration rate in patients, but found something significant in secondary endpoints. So letting more time spent by these patients after 14 days group, the group with the recombinant alkaline phosphatase, had a significantly higher glomerular filtration rate with respect to those receiving placebo. And so this study is promising. There is some research in children that is very preliminary with these drugs, and we are waiting to see more results in future years. What can we do regarding fluid overload in this patient? This is a very interesting, one of the few studies regarding timing of CRT and timing of the attempt to reduce fluid overload in children. These children were very severely ill. Many of these were septic. And the authors showed that an early timing before 50 hours from PICU admission of CRT was able to improve the mortality of these patients. They also showed that fluid overload in these patients was clearly associated with death, as you can see here, starting from 10 to 20%, there was a significant increase in mortality of these patients. So the question remains if there is a biologic plausibility that cumulative fluid balance is indeed associated with AKI and with death of this patient, and if probably the prevention of fluid overload and the aggressive treatment of fluid overload in septic AKI and severely ill children might be an attempt to save their lives. Is there room for non-renal extracorporeal therapies in septic children? Something very interesting has been attempted by again the group of Professor Goldstein with this selective cytopherectic device. These authors conducted a sort of novel therapeutic extracorporeal option by letting the blood flow after citrate anticoagulation, so in a low calcium environment, to flow outside the hollow fibers of a polysulfone filter. And as you can see here, outside the whole fiber, the white blood cell in a low calcium environment tended to aggregate and tend to be immunomodulated. So these authors ran a first study in 16 children with sepsis that were treated with this treatment, and not only they were able to achieve the FDA approval for the utilization of this strategy, but also that they have an incredibly high rate of survival in these children, much higher than was the predictive severity score were predicting, by the way. And so this is one of the most promising strategies currently available. We also have some reports of the double application of adult strategy, like in this case, high cutoff filter followed by a sorbent. In this case, this patient immediately had an improvement of its septic episode. Again, with my colleagues, we treated with the PMX cartridge, a 15 years old girl with very, very severe septic episode, and the time association with the start of the treatment and the recovery of her hemodynamic condition was incredible. And in this case, there was almost certainly an association with our treatment. The PMX direct hemoperfusion has been conceived even for children. We have now a smaller cartridge. We know that endotoxin is released in many conditions. Some years ago, we showed with an observational studies that after cardiopulmonary bypass in children, there is a release of endotoxin, probably from the gut. So this is possible in many hemodynamic conditions in children's. And doctor from Moscow recently showed that in 15 septic children treated with the pediatric cartridge, he was able to show that there was a significant reduction of the endotoxin activity assay levels in these patients, and some important results in terms of hemodynamics and drug doses and body temperature. So this cartridge showed some effects in this very small case series. We also recently have a case series of children treated safely with the CytoSorb cartridge, and these authors were able to show, interestingly, how significantly the IL-6 and IL-10 cytokine levels decreased with the application of this strategy. So in conclusion, septic AKI children is frequent and severe. The pathophysiology is essentially and currently identified as a secondary distal involvement of renal function in the context of systemic inflammation. We currently are uncertain about the role of hemodynamics. For sure, we know that aggressive fluid loading resuscitation should be somehow regulated and carefully managed. Septic AKI is associated with increased death, increased hospital length of stay, and decreased functional status of our children. So it should be identified early and prevented as much as possible. Prevention is currently the mainstay of septic AKI. What we can do now for septic children is probably try to apply some novel technology, especially in children who are already receiving an extracorporeal dialysis. We've seen that many of these children have the need of CKRT when a severe AKI occurs in a septic episode. I do not endorse a routine application of a non-renal blood purification strategy so far, because the evidence, both in adults and children, is currently not adequate to endorse this kind of treatment in children as a routine application. And with that, I thank you for your attention.